Good evening, everyone. My name is Simiran Choudhary, and I welcome you all on behalf of Voice of Healthcare to today's session titled Understanding Blood Cancers, the Not So Rare Cancer, organized by Voice of Healthcare and supported by Viatris. Though we often label as rare blood cancer like leukemia, lymphoma, and myeloma are increasingly common in India. Yet they remain underdiagnosed, underrated, and often misunderstood. And today's session brings together experts to explore the key challenges in early detection, treatment access, and the role of academic and clinical system in improving outcomes. And I'm pleased to welcome our esteemed speakers for the panel discussion. Dr. M. Gopinath, Consultant Hematologist, MGM Hospital, Chennai. Welcome to our show, sir.
Thank you.
Thank you so much. It's a pleasure having you. Dr. Santhosh Kumar Devadas, HOD and Chief BMT at Ramaiah Memorial Hospital. Welcome to our show, sir.
Thank you.
Thank you so much, sir. Pleasure having you here. Dr. Biswajit Bhuyan, Associate Professor, Hematology at Kalinga Institute of Medical Sciences. Welcome to our show, sir.
Thank you.
It's a pleasure having you, sir. And now, without any further delay, I would like to start with our conversation. I would like to ask my first question to Dr. Gopinath. So, from your experience, how has the presentation of blood cancers evolved over the years in India, and what are the typical delays you observe in diagnosis or referral? So, we cannot hear you. Dr. Gopinath, we cannot hear you. I think there's some technical issues, so we'll wait for that. But meanwhile, I'll ask my next question to Dr. Santhosh. So, what are the usual hurdles faced in facilitating the bone marrow donations, particularly around donor matching, public awareness, and logistical readiness?
Thanks, Dr. Simran, for the question. Till Dr. Gopinath joins, I'll just cover the previous question, answer the previous question, and then move on to the second question. So
Sure.
many times, blood cancers are misdiagnosed as anemia with low hemoglobin, or ITP where there is a low platelet, which are all benign disorders. Many times, lymphoma can be misdiagnosed as tuberculosis. Many times, multiple myeloma, which involves the bone or the kidneys, can be misdiagnosed as a kidney condition or a bone condition. So it is important to understand these fallacies and misdiagnosis, and the referral community or the physician community or other doctor community should be acutely aware of these disorders before making diagnosis. And coming to your second question regarding the regarding the bone marrow transplant. Bone marrow transplant, though, is a very important part of management of all of these blood disorders, namely multiple myeloma, lymphoma, or leukemia. Before we do a bone marrow transplant, patients require to get initial treatment where the disease burden can be reduced with additional what we call as a induction treatment. Subsequently, bone marrow transplant is a very important part of treatment to prevent a relapse or reduce the chance of relapse in patients with hematological malignancies. And in sometimes even benign disorders, bone marrow transplants are being used. There is a lot of need for education in the general public regarding where and when the bone marrow transplant is of use. For example, many times just the transplant name itself brings in fear, and many times patients back out from going through the procedure, though the risk benefit is in favor of doing the procedure. Many times there is also when the patient requires an allogenic transplant, that is when the donor is required to do the transplant, there is a lack of donor. Even though the family can many times donate, the family backs out to donate. Though it's very safe for families to donate their stem cells, it is just like blood or platelet donation. The stem cells come back into their body within the next 24 to 48 hours. So it's a very safe procedure for the donor. Many times that there is miscommunication and donors back out before donation of stem cells. This is one more barrier. The third barrier is definitely financial resources. Though many times there are excellent government schemes, these are variable in various insurance programs in various states, and many times there is a financial burden that the family has to face, which may lead to a reduced usage of bone marrow transplants. In our own experience, we have recently, not recently, about a couple of years ago, we published data of usage of transplant in a disease called multiple myeloma. If around 80% of patients were fit for transplant, only 40% of patients were offered transplant by referring physicians. And though 40% of patients were offered transplant, only 20% of patients went ahead and did the transplant. This is a publication that we published about a couple of years ago in Egyptian Journal of Hematology. So these are the various factors that play out in the community that lead to reduced uptake of this life-saving procedure.
Thank you so much, Dr. Santhosh, for answering that question and explaining to our audience how what are the hurdles normally faced. I would like to reconnect with Dr. Gopinath. Sir, can you hear me?
Yeah, I can hear you. I can hear you clearly.
That's great, sir.
Yeah, I
So,
can hear you. I'm sorry for the
although
small. Yeah.
no problem, sir. Although Dr. Santosh helped us to understand the how has the presentation of blood cancer evolved over the years, but I would like to know from your experience as well, how has the presentation of blood cancer evolved over the years in India, and what are the typical delays you observe in diagnosis or referral?
See, first, we should all agree that the once upon a time we never had a good diagnostic tool. Various therapeutic options for treatment of these blood cancers. But now, since we have improvement in diagnostic techniques, I would say that the percentage of diagnosis and difficult diagnosis. Sometimes, maybe 5-10 years back, we kind of get these cases going. We will not be able to diagnose to reach to a particular diagnosis. Say, for example, if I say an acute leukemia presenting to you with HLH, an undiagnosed liver failure, which may be a lymphoma. So all these cases we used to miss almost 10 years back. But now, since with the advent of diagnostic modalities and all the other ancillary techniques, we're able to pick up more blood cancers or more difficult diagnostic dilemmas than before. And the referral pattern, I would say, reasonably in the third tier cities, it's better. So at least the physicians and primary physicians, treating physicians and pediatricians and gynecologists are well aware to refer to a hematologist early or a medical oncologist early, particularly when they deal with blood cancers. But whereas still in the second tier cities and some rural areas of the rural parts of the country, where again the referral system needs to be strengthened even more. That's where I feel. Per se, with regards to the prevalence, that was your first part of the question. With regards to the prevalence and incidence, I would say it's on the steady rise. Maybe we are diagnosing more. That's why our pickup rates are more. So that's why I can find the prevalence and incidence of hematological cancer overall in a slightly increasing rate. With increasing population, increasing diagnosis, yes, we are on the rise of hematological malignancies.
Thank you so much for that answer, sir. And my next question is to Dr. Biswajit. So, what role do you think academic medical institution can play in improving the early detection and standardized treatment protocols for blood cancer, especially in underserved regions?
Well, academic medical institutions are different from other corporate or some cancer centers. The difference being is that in addition to patient care, education and research are also taken care of, and that is a very means vital aspect. And means apart from this, so these academic centers they conduct this outreach and health camps and mobile clinics, so, and they also do this health education campaigns. So, which are a part of means their like community medicine department and means preventive medicine department. So these all, they add up to the knowledge of leukemias or lymphomas or blood cancer, and they promote a means education and a community service to those under means those privileged areas. Second, so there comes an concept of training and capacity building. Like they do equip the means at the primary level, the ASAs, the primary care doctors and the lab technicians, and so they train them to identify the red flags for leukemia, lymphoma, or myeloma, and also there is a telemedicine department in those medical colleges. So and so which enable continuous medical education and case discussion with those rural areas. So where actually means all those things are not available.
Thank you so much for that answer, Dr. Biswajit. My next question is to Dr. Gopinath. So, what practical steps can be taken at primary or secondary healthcare level to enable earlier diagnosis and referral of blood cancer cases in India?
Yeah. First is the so-called education program. The prime now we have various government schemes to empower rural healthcare and urban healthcare. So we can teach the primary physicians who are the first level of contact for any patient to the community at least. So the simple warning signs that has to be taught to them, like fever, prolonged fever, weight loss, night sweats, any unexplained bone fractures, anemia, some kind of variations in blood counts. Because till now, I can see from most of the blood counts or some hematological disorders from the rural or secondary cities, they just still only do a hemoglobin or only a platelet. Only the cell count of interest is what they keep doing. So if you teach them to do run a complete hemogram, and that can tell you an array of disorders that any patient or any person can have. So physician program, physician teaching program is an essential. In fact, they should be able to not only hematological cancers, they should be taught about the other various myriad of cancers that the community is undergoing through. So that is one thing. And second thing is doing running nowadays. It is quite, at least in the urban setting, it's becoming common to have MHC checks, master health checks. So similarly to the urban community, I mean rural community also, if we run a masterly health checkup at least after the age of 45, I think we can pick up at least this incipient or indolent blood disorders at an early stage. So these two I would mainly suggest, and obviously a constant referral system would kind of bridge the gap is what I'm thinking.
Thank you so much for that answer, sir. My next question is to Dr. Santhosh. Sir, in your view, what are the immediate infrastructural or policy changes required to make advanced treatment like BMT and targeted therapies more accessible and affordable in India?
Thanks for the question, Simran. Uh, as previously discussed, bone marrow transplantation, or also called hematopoietic stem cell transplantation, is a crucial component of management of blood cancers. Uh, but as we are a low middle income country, the government generally is has a challenge of other diseases which really take the limelight in terms of funding. So many times, patients, though the blood cancers are becoming rampant, many times patients do not get the benefit of various government schemes. For example, if you look at the state of Karnataka, where I practice, there is absolutely no support from the government agencies for bone marrow transplant in the Ayushman Bharat scheme. Unlike, for example, some other South Indian states like Andhra Pradesh or Tamil Nadu, where there is a reasonable support. So again, this is a matter of political will that needs to come through to help these very vulnerable patient population. Other issues that can be improved is that if you look at the Indian Society of Bone Marrow Transplant Registry data, we do about 3,000 transplants every year in our country. But each center does only say 20 or 30 transplants, or some centers do even less than 10 transplants. So there is lack of consolidation of care, and there are only few centers with a large number of patients and with a large experience, which in turn means there is an increased benefit in terms of improved outcomes. More the experience, more the benefit in terms of outcomes. So we need transplant centers to do more and more transplants to get better outcomes. There's also a need for a policy to maintain that the transplant centers are adhering to the highest quality standards. In India, unfortunately, the NABH or the other accrediting bodies do not accredit bone marrow transplant centers. So we are dependent upon international accreditation, like for example, the FACT accreditation, which is a body that is there in the United States, which accreditates the bone marrow transplant centers regarding their quality of work that is being done there. So that is something that we probably need to develop in our country and make sure that the care provided is of the highest standards.
And so, in addition to that, what systematic or community level intervention do you believe are needed to improve bone marrow donation rates in India, whether through public education, national registries, or institutional collaborations?
A very important topic you have raised. There is a significant need for education in the community. There is a misconception in the society that bone marrow transplant is a surgical procedure. In fact, it is a medical procedure. It's just done like a blood donation and a blood that goes into the to the patient. So the donor donates his stem cells via blood, and then it is infused into the patient who requires these stem cells through the blood itself. So there is a lot of fear that the donor may suffer by donating. That is not the case. There is a lot of data that is available regarding the safety of the bone marrow donation procedure by various agencies, and this is something that needs to be driven into the society. At the same time, many times we do not find the right donor in the family. Unlike the United States or Europe, where there are large voluntary donor agencies which will eventually find a donor for you, that is lacking in India, though we have a couple of agencies like the Datri and the Bombay Registry, that is not enough for a population of 1.3 billion. Hence, there is a need to enhance our voluntary donor rates that may be of great use for blood cancer patients.
Thank you so much for that answer, sir. My next question is to Dr. Biswajit. Sir, how can academic institutes and medical education program be better aligned to prepare future clinicians for the growing burden of hematologic cancers, especially in low resource settings? Sir, you are on mute, sir.
Okay, the only practical solution is to integrate the hematological oncologies early in the curriculum, right? By dedicated modules like focus training modules in early science, basic hereditary differential of hematological malignancies. Second is that these hematological malignancies should be made case wise. So it is a case based learning. Third is that simulated learning. So the students should be trained to interpret basic peripheral blood smears, so basic flow reports, and of course sometimes even if the marrow reports also. Third thing is that uh, clinical rotations into the hematology department. So many times we see the medicine and pediatrics student, the medicine and pediatric PG students, they they have no hematology posting in their curriculum. So means how can they be oriented to that? So these kind of rotation in hematology department should be made in the curriculum. Means in the curriculum of NMC. Third thing is that the faculty development. So So, especially in the Department of Medicine and Pediatrics, so there should be faculty development program regarding the awareness and early methods of detection. So many times we find that even our medicine and pediatrics means colleagues are confused about so what to do next and what investigations to set. So whether cytogenetics should be sent or not. So these kind of faculty development programs can of course increase their awareness and also robust when to refer a patient to a hematologist. So these all and of course encourage. So we should always encourage the means local means research on local disease pattern. So some areas, so sickle cell disease or some hematological malignancies are more common. So we can just focus on this local disease patterns.
Thank you so much, Dr. Biswajit, for that answer. And with that, we have come to end of our session. So I would like to thank all my panelists for such insightful and thought-provoking discussion and the expertise insights you guys have shared with us to educate and aware our audience. And today's session has highlighted that blood cancers, while often called rare, are the growing concern now. And addressing them require early diagnosis, better awareness, and improved access to advanced treatment like BMT and stronger academic clinical collaboration. And so let's continue working towards a future where every patient with blood cancer has access to timely and affordable, effective care. Thank you so much to all the panelists for taking out time out of the schedule and spreading this awareness with us. It means a lot. Thank you so much, all.
Thank
Thank you.
you.
Thank you.
Thank you, sir. Thank you so much.